Good morning, everybody. Good morning. Just as people are coming in, we're going to make a start. Welcome to day 2 here at Liverpool. Welcome to all of you who are joining online. I don't know about you, but I really enjoyed day 1. I hope you enjoyed it as much as I did. I did have one bit of a concern with Professor Whitty's assertion that many of our patients would be having their heart attacks several years after they died. It brings a whole new complexity to advanced care planning discussions. Can I remind us all to turn off our phones or to put them on to silent? If you would like to ask questions and you're online, please go down to the bottom of the page. The Q&A box is underneath there. And if you're here in Liverpool, please use the Slido as we used yesterday. Details, I think, are going to be on the screen. Yep. 2 of the standout themes from yesterday for me were collaboration and the importance of the connection between palliative care and frailty. This morning's plenary picks up on these 2 themes in a truly, I hope you'll find it, inspiring account of what can be done by a very motivated and skilled team from Hull to support people living with frailty, to live well, to age well, and to die well. Our speaker, Dan Harman, is a consultant community geriatrician and strategic clinical lead in frailty in Hull and East Riding. Dan and his colleagues have developed a community frailty service, including a 7-day urgent community response, which is just what is needed in so many parts of our country. There is so much to learn from Dan's presentation, which I hope will inspire you too. Dan, thank you for coming to share your experience with us. Thanks.
Morning, everyone. Can you hear me okay? I'll put one of these mics on. Day after the night before, it's great attendance for a second day of conference at 9 o'clock in the morning. I'm sure many of you were at the breakfast session as well. But really, for me as a geriatrician, see so many people interested in frailties is really, really exciting. I'm going to try and move around a bit rather than stand behind here because I think I'll just waffle on if I stay over there. But as well as being a geriatrician working in Hull and East Riding, nearly full-time in the community now, I just do my own calls in the hospital. I'm also one of the strategic clinical leads for frailty across our ICB, which I think is really important. We've got some frailty recognition at that sort of senior leadership level. And I also work for NHS Elect in the improvement team in the system Wide Frailty Network, which has been really helpful to see how different frailty models are developing across the country and to try and influence some of those models of care. But I think more importantly, one of the things I'm really passionate about is my role as a trustee at House Hospice, where colleagues are here today. So that role, which I've had for nearly more than 6 years now, I think has helped me develop an insight into how the hospice world can integrate with the care of older people affected by frailty. That lady, the most important person that we'll hear about today is Jean Bishop. So many of you will not know Jean Bishop. I'll explain more about her later, but where I work is the Jean Bishop Integrated Care Centre, which is based in a socio-economic deprived area of East Hull. So in the next 45 minutes or so, I'm just going to run through the background around frailty, some of our strategic aims at place within Hull and East Riding, and how they can be used elsewhere across the country, how we delivered an improvement in older people's care, and how we measured outcomes across our system. To touch on a theme that was addressed yesterday around culture and system thinking, I think it's important to focus on that area as there's a lot of overlap in services in the care of people living with frailty. To consider the role of the hospice and just a few top tips. And I think what, particularly the New Zealand and the West Yorkshire teams yesterday, what was clear for me was having a really clear strategic vision around quality improvement. And ours across Hull and East Riding was to deliver the right care in the right place at the right time for people living with frailty. It was pretty obvious, really. And we cover a large geographical area across Hull and East Riding. So about 1,000 square miles, population of 700,000. If you extrapolate frailty figures, we're looking at about 4% of that population, so about 28,000 people living with moderate and severe frailty. So a lot of work and a lot of potentially unmet need. The beautiful building in the bottom right-hand corner is the Jean Bishop Integrated Care Centre, and that was built between 2016 and 2018 and opened its doors in May 2018. The circle in the middle is the services that we have developed over the last 5 years. We're starting on a journey of anticipatory or proactive care and then moving more into a reactive model of care. And as I'll talk about the workforce shortly, our service delivery and our workforce has grown significantly to meet this challenge over the last 5 years. So I'm not going to teach you to suck eggs. I think we all know what frailty is, but I'm just going to, in one slide, just try and summarise to me what I think frailty is, and that is the loss of physiological inner reserve due to cumulative deficits that occur over an age cycle. And that's particularly relevant in Hull and East Riding, where we have an average life expectancy that's 10 years different as you drive sort of 4 miles down a road from Hull into East Riding, your life expectancy improves. So we see a younger frail population in Hull and a potentially older frail population in the East Riding. And of course, minor stressor events are what cause people with frailty to deteriorate. So things like an infection or a change in medication, as I've experienced with my own family just this weekend. So really, lots of complex definitions of frailty, but decreased resilience to stress is the way that I always like to think about it. An internal stressor event or an external one, such as a bereavement or change in environment. And I've felt for many years that frailty care needs to change. It's not right the way that we care for older people living with frailty. Sometimes it's embarrassing, to be honest. And my personal experience as a junior doctor and then as a registrar was in the life cycle of my Nana Mary, who passed away when I was a registrar in a care home in Hull. And the last 6 to 7 years of her life were really quite painful for her and for us as we struggled to navigate the care system. She was diagnosed with dementia 3 years after the onset of her symptoms, and we watched her physically deteriorate. And so I think my Nan's experience and our experience was of a frail elderly person as a label. She presented late, in crisis, with episodes of delirium, immobility. She invariably ended up in hospital. And her care there, whilst the care received was excellent, the environment was wrong for her at the time and made her dementia so much worse. It's the last picture with my son, who's now 13, so it's quite a while ago that these photographs were taken. And I think that frailty care needs to change because, as Professor Whitty was saying yesterday, more eloquently than I could, the data tells us that things need to change. So this population age profile is for residents across Humber and North Yorkshire ICB, so our ICB. The black line is the NHS England statistics, and we can already see in our area we have a swell of older age people against a smaller size, younger age working population. And then if we look at the UK in general over the next 20 years, our pensionable age residents will increase, but the number of children being born is decreasing or expected to decrease. So we know at the moment that frailty care costs the UK economy nearly £6 billion per year. We know that a large proportion of our inpatient beds in hospitals and community settings are occupied, most of the time necessarily, but sometimes unnecessarily, by people living with frailty. And we do know that this is going to be a significant impact on services over the next 20 years as our demographic changes. And of course, on a personal level, as I become older and potentially more frail, not frail yet, but who will care for us in the future is the question that we need to ask. And of course, in talking about older people and then talking about frailty, the two are linked but not necessarily the same. It's really important that we can identify people living with frailty so that we can offer care differently. And there are tools out there that can help that are quick and effective to use and have a strong evidence base. Professor Clegg's work around the Electronic Frailty Index is something that is utilised in many systems around the country now to segment the population and risk stratify people at risk of not being frail, mild, moderate or severe frailty. It's not a diagnostic tool, it's there to try and promote us to use the right services to support patients. There is a similar tool in hospitals called the Hospital Frailty Risk Score, which is not used as widely. But if we go back to clinical assessments, we think about the way we assess patients. We think about frailty syndromes, so somebody presenting with a fall or delirium, or a new incontinence. We can think about the phenotype model in the bottom left-hand corner, the way that somebody would change over their life cycle in terms of their level of functioning, perhaps if you work within primary care, how they would get to the practice, walking in independently, to then a family member needed to bring them, to then asking for a home visit. And these are signs that somebody's becoming more frail. And then what is universally accepted, well, certainly in our country and most of the Western world, is Ken Rockwood, the Canadian professor, his clinical frailty scale, the Rockwood CFS, which you can see featured in the top right-hand corner here. A 1 to 9 point scoring system, very easy to use. What I like about using Rockwood, and our team do use it, is the way that it focuses the evidence base around the interactions that might support a person at different stages in their frailty trajectory. And a plug to the top right-hand corner is it's free to download on any smartphone as well. And it walks you through, we use it with all our staff groups, walks you through how to use the tool. But I suppose if we identify frailty, what's the point if we're not going to do anything differently? And the work of Professor Conroy on NHS Elect as well, we really want to get to this place where we have a frailty registry. So we're using risk stratification tools, we're using the Rockwood Clinical Frailty Score to validate these risk assessment tools, creating a registry across a health and care system so that we can then offer care differently. This holistic assessment of an older person that includes determining the treatment paradigm between palliation and or curative treatment, and addressing admission and readmission risk to hospital. But I think most importantly, if this is done in an anticipatory fashion, the importance of including the individual and their families in those decisions and respecting their decisions. So just to touch on comprehensive geriatric assessment, it is the cornerstone of frailty medicine. As I'm sure you're aware, it's something that's multidimensional, looking at both physical functioning, psychological and social well-being. It can't be delivered by one person. I don't believe anybody has all the skills to do CGA in isolation. And it does require a certain set of clinical competencies and therefore training. But if used and utilised properly, it can reduce adverse outcomes. And there is now a strong evidence base that CGA, comprehensive geriatric assessment, in a hospital and in a community setting can improve outcomes for the patients and outcomes for the system as well. So it is the gold standard of frailty care. And there is emerging evidence that it can actually reverse frailty, particularly if we focus on structured medication reviews and inappropriate polypharmacy and falls risks. So I've talked a little bit about the background, what we were trying to achieve in Hull as well in terms of moving away from that experience that I had with my nan, more to a more holistic approach where an older person living with frailty is deemed to be a person with a long-term condition, and that we have timely identification of frailty and interventions in a community setting closer to home that move away from this episodic and disjointed care. And I'm going to hand over for a sec now just with a short video to Ray and Val. So when we opened the Jean Bishop Centre in 2018, Ray was one of our first patients and was really reluctant to come, didn't know us, didn't trust us. And I'll hand over to Ray, let him tell you what he thought about the care he received.
It's been marvellous. I come round. They've really looked after me after being there.
Yeah, it was he was surprised when because even the morning they were coming to pick us up, he wasn't keen on going, but when we got there, they really looked after us, didn't they?
I could tell you straight away. Yeah, that was great. If I was paying private, I couldn't have been any better. I like the specialist. He said, just call me Dan. That made me feel at ease. Just call me Dan, he says. And I'm a lot happy now. I know I'm taking the right tablets. They've looked after me, took me off the other tablets and half a water tablet, and lot happier. You know you're getting the right treatment.
Nothing was a trouble for them to do for you. You saw a physiotherapist, didn't you?
I wonder, I sort of wanted to know how I got about, and I said, I can't get about. And she says, we'll get you an electric chair. See, it was only a couple of weeks ago. I wasn't waiting long for it. And I said, no, so we got that ordered. I'm able to get in the back garden because council built me a ramp, big ramp, to go from here into our back way, so I could get down with a wheelchair, big ramp, and I've been wanting to get down there.
The thing is, they had the ramp built, but I can't push him back up the ramp. No, push him down, all right, but I can't get him back up again, and that's the problem of us not getting him out.
Oh, I'm getting out now.
That's it, isn't it?
I couldn't get. It was in our back kitchen, wasn't it? And I kept looking at it and looking at it. And I got on it all day, didn't we? And I got round the corner on it, near the corner shop. And I said to her, well, I'm going to carry on to park. And I did. Carried on to park, didn't we? And had the coffee.
Yeah.
Didn't think I could.
Yes.
Not first time. That said, so I said to her, and now I'm getting a bit used to it. I said, we'll have a wheelchair taxi, maybe to Marx's, where I can get another drive straight on and come off, and I can go and have a coffee in Marx's and go around the store. It's nice that to go around the store. I wonder if it wasn't for the Jean Bishop Centre, I won't be here. I won't be set here.
Thank you. What a powerful video. Ray passed away actually within 12 months of this video. But Val describes those 12 months of having her Ray back again. And I just think, you know, like, we make medicine so complicated, but the stuff he needed was a medication review, accessing in and out of his house and just somebody to listen to him. And we've just somehow lost our way because of staffing, the way that our services are structured. And I just think there's so many people like Ray that would benefit from a more comprehensive assessment closer to home and in a timely fashion. So very grateful to Ray and Val for that video. Back to the boring stuff. But the important stuff, isn't it? The strategic aims, stuff like this with Ray and Val is only achievable because of the way that teams work differently together. We have some really brave commissioners within Hull in particular and East Riding, but we started in Hull, who were able to do something unique and pull all the providers together and challenge some of the behaviours that exist between provider organisations so that we would work together collaboratively on this piece. And it wasn't just health, it was local authority at the table as well, the voluntary sector, and even the fire service. The fire service run our falls pickup service out of hours. So when somebody's lifeline's pressed, we don't have many fires, thankfully, but we've got trained staff that can go out and alleviate any suffering in the home and get people into the right services the next day, and indeed take people to hospital if it's necessary. So we wanted to shift the focus to this early help and prevention. We recognise, as Max alluded to, the need to respond in crisis as well, which I'll come on to, and the importance of respecting patient choice and preferred place of care. In doing this, we didn't set KPIs of we needed 20% reduction in ED attends and admissions. We felt that that would come, so we were more specific about just reducing the demand rather than putting a number on it. We wanted to make sure that this same offer of care was delivered to people in their own homes, but also to people in care homes, because that is probably where our greatest need is in an older population. And I mentioned about not working in silos. Patients are involved right through this planning process in terms of in how the design of the service was, how the service ran, and how it's changed over time. And as I'll come on to constantly evaluate and refine the model of care over the last 5 years. I'm not going to touch too much on this slide. This is new information that I think is coming out this week, which is the NHS Proactive Care Framework, which I've tried to summarise in one slide and failed. So the way I see it is around identifying the right patients, a holistic assessment, MDT assessment with interventions, personalised care planning and support planning. They're the three key themes that came out for me. And the diagram on the right refers back to the document that I should have mentioned earlier, which was the British Geriatric Society publication on how to complete comprehensive geriatric assessment in primary care. So this is just a bit of a composition of our team with Jean in the middle. So as a consultant, I'm just one member of the medical team on any given day in the model. We've got GPs with an extended role in frailty, advanced nurse practitioners as part of that clinical team. But you can see all the multiple disciplines here that we have working for the patients, working for multiple provider organisations. But of course, the patient doesn't know that there's 5 or 6 different organisations working together. It shouldn't really matter. What hopefully they recognise is that they're receiving the best care that we can offer. And just to go through the process a little bit, so we run the Electronic Frailty Index across the whole of primary care. That's identified about 3,200 residents in Hull alone before I move on to East Riding. Those patients are at risk of severe frailty, so EFI, severely frail. They're all then contacted by their GP practices to consent to referral into the Jean Bishop Centre. We then contact the patient. We have full access to their primary care records, secondary care records, and mental health records. And that's the piece around integration that I think that was a hearts and minds piece. It didn't cost anything really to do that. It was more about the data governance side of the barriers that we put in place in the way that we organise care. The patients are then contacted by a member of our team. We complete something called a patient concerns inventory, which is a list of prompts of skills that people wish to maintain, things that they've lost, things they're worried about, falls, social isolation, fuel poverty. These are things that come up quite commonly now. And that questionnaire was designed with patients through a Delphi survey at our local university. Again, has had numerous reiterations. And then the patients arrive. We've got a dedicated transport service for those that need it. The uptake's about 40%. Patients are with us for the duration of the morning, where they go on a bit of a, well, they call it an MOT, many of them, but it's a bit of a carousel between the different clinical rooms. So they'll see a doctor or nurse practitioner, a pharmacist and a pharmacy technician, physio, occupational therapist, social worker. We encourage them to attend with a carer, if they have one, or a family member, so we can carry out an assessment of care need. The carers support and information service are part of our core team, because we recognise that that's the time when people flip into crisis is because of carer strain. We have diagnostics on site. We can do plain film x-ray, we can do bloods, bladder scans, ECGs, the basics. Anything more lofty than that, we need to refer people to hospital for a scan. We don't have a community diagnostic service yet. Advanced care planning forms a really important part of the work that we do. About 70% of patients that we see have a respect form completed as part of that consultation. And for me, the worst time to be having advanced care planning discussions is on my post-take ward round. I'm on call next weekend. I'm not looking forward to it because it's not the right time to have these conversations. This is, and it's really rewarding to be able to have the time to do this properly, and people understand the advice that you're giving them, and it's documented, and that information is shared across the system. We can also do this model virtually. So for people that are in, going back to Professor Whitty's piece yesterday, in hard-to-reach areas, we have trialled and evidence that we can actually send somebody into the patient's home with a tablet device. It would be one of our therapists, and the rest of the team dial in remotely to carry out a comprehensive geriatric assessment between us. The patients, when they're in the Jean Bishop Centre, would leave around lunchtime, and then we have an MDT in the afternoon. We sign off a care plan that's then shared with the patient and the multiple providers that we've just discussed. We're not there with an integrated care record that is live and updated as it moves through the system. I'm not aware of anywhere that is yet, but that's where we need to be. One of the things that's been really exciting around our model is the way that other subspecialties have become interested in this at place. So we now have a Parkinson's frailty model running from the Jean Bishop Centre, and we have either weekly or monthly MDTs that involve colleagues from respiratory medicine, from our mental health services, from diabetes, and from the hospital falls team, all supporting the same patients in a more integrated fashion. So just a moment on the outcomes now as well. So again, working differently together, we agreed a minimum data set across the system so we could track patients through primary, secondary care and our services. And what we can demonstrate over the 5 years is a sustained reduction in scheduled primary care appointments and unscheduled secondary care activity in terms of emergency department attends and admissions. And those benefits for the system are even greater in those that are deemed to be frequent flyers, so 3 or more ED attends in the last 6 months. And also of greater benefit in those patients who live with a long-term condition that are listed here, plus on the Ken Rockwood Clinical Frailty Score are either moderately or severely frail. I should just reference, I said we use the EFI to refer patients in, but we diagnose frailty using the Rockwood Clinical Frailty Score. And we've compared the data between those two sets. The run chart on the right that we can see is, I mean, you can spot the pandemic. All slide sets look like this, don't they? Around, I have not even put the timeline on it, it's so obvious. But I think the pleasing thing in our system is we haven't returned to pre-pandemic baseline activity in terms of older people's attendances in hospital. You'll note that this is for patients aged 80 and above, and I've been talking about frailty and age being a poor proxy, but as a system, we are not there yet in terms of using CFS universally across the system. So for the hospital data here, I'm using their SUS data, which is age-based. So as a clinician, more importantly for myself and colleagues is, what's the patient experience from this? I mean, we heard from Ray, but that's just one story. And Professor Mercer, Fliss Mercer, I think he's here today. I've seen her this morning. Fliss and Miriam Johnson have really helped us to evaluate the patient experience. And again, another example of collaboration between different specialties. I am not an academic, so working with Fliss has been really rewarding for us as a team, because here we can now demonstrate a sustained improvement in quality of life markers at 10 to 14 weeks post-assessment that is statistically significant, more so in the psychological domain than the physical domain. But also another publication this year by Fliss and colleagues, a qualitative study looking at patient experiences. And the Wordle here, I think, represents everything that we would aspire to deliver through our model. But it's also given us some areas to focus on for improvement as well, particularly around the forewarning of an advanced care planning discussion to patients and integration and follow-up both within our own service and primary care. So moving on, so proactive care, I love it. It's my favourite bit of the job. The tangible benefits are more longer term, I feel, but we need a reactive, responsive model in the community as well. And obviously throughout the country now, UCR is mandated to be delivered across all ICBs, so that's the urgent community response. But we were kind of doing this during the pandemic 7 days a week anyway. We had a frailty advice and guidance line, so it was quite easy for us to shift this work to our team. And what we see here is that 7 days a week, 12 hours a day, we have clinicians taking calls directly from care homes, from our ambulance crews, from GP practices, and they'll come through, triage straight to a clinician. We'll carry out either a remote consultation via video or telephone. If it's a clinician on the ground that's calling us, we often won't convert it to a video call if it's a paramedic that's there. We've also got the ability to send out clinical support workers with devices called Tyto Care, which are digital stethoscopes. So we can carry out heart and lung examinations. It's got a HD camera. It's really good for cellulitis and any oral lesions or swelling. And that allows us to deliver across this 1,000 square miles with just 1 or 2 doctors at a base at the Jean Bishop Centre. We have also got urgent care practitioners in our team as well, so we can send somebody out who's qualified to examine as well. We can carry out near-patient testing. We can electronically prescribe across the whole of Hull and East Riding. And this is all through challenging the norms within our system. And I think one of the things we're still working on, we're not quite there, is the outputs from urgent community response. Lots of patients we can see and solve at that time, don't need any follow-up. Some patients we bring onto our frailty virtual ward, which has been operational for about a year now. We can pull people into that anticipatory care model that I described earlier, and we have created slicker referral pathways into our intermediate care beds in the community and also referral routes into the hospital. If you look at a system benefit, paramedic conveyance of people living with frailty was about 70% prior to the initiation of urgent community response, and it's consistently around 17% now. And it is reaching into the most deprived areas of our city and East Riding. And the makeup of that team is a little different. We don't need quite as many team members to deliver the urgent side of the response, but there are significant gaps. The UCR funding didn't include funding for adult social care or the voluntary sector. Mental health pathways are the same as they were prior to the initiation of UCR. So a lot of it relies upon interdependencies between teams at a place level and the existing urgent care pathways. I should have mentioned this earlier, but our operational management in this is key. The operational manager that runs our services is just so helpful at trying to unpick a lot of these issues. And as clinicians, it makes our job so much easier. So I just want to move on to how it's possible to do something differently. I mean, it has been painful, but I think that if we go back to these 6 conditions of system change, these are the conditions that hold a problem in place and really don't help us to fix it. And what we see, particularly in winter, is a good example is winter pressures. So there's 10 key priorities for the NHS. A lot of that is focused around, sorry, my screen just went off, focused around the emergency department activity. And what we tend to see is, because that ultimately is where a lot of the problem, particularly the focus, needs to be when everything seems to go wrong. And so we change policies, practices, there may be some resource allocation for some temporary staffing or a new ward to be opened, and we see some tangible benefits, but they're never long-lasting because we haven't unpicked this sort of second level of semi-explicit and the third level of transformational change. And a lot of that is around, again, touched upon yesterday, relationships and power dynamics that exist within our system, and barriers that just simply don't need to be there if we just worked more closely together. The mental models piece is around the sort of fixed, firm beliefs or attitudes that allow us to hold a problem in place. And the one that I often see as a clinician is, that isn't mine to sort out. You know, that's frailty's job. And we just can't work like that because our patients are moving across our system at all times. I don't have time to go into the next section today, but if you get time, go on the NHS Employers website. They published an article just a few months ago around the 6 ways to create a culture for integration. And it really speaks into some of the work that we've been trying to do. Busy slide, not going to go through it all. Again, these slides are being shared. There's 3 links, well, there's 3 papers here that are worth a read. Plug for the System-Wide Frailty Network toolkit. There's some good examples as to how we can unpick some of these frailty principles in there with some place-based solutions in there. The British Geriatric Society joining the DOTS paper, I think that was published earlier this year, and the Geriatric Medicine GIRFT report, Getting It Right First Time. These are 3 key documents for me that if we adhere to the principles that exist within these documents with some place-based solutions based on the strengths we have in our system already could make a massive difference, and it is evidence-based. So I've already touched on, so I've tried to condense the 30 or so principles into 14. I've spoken about the first 3 in particular and also something around the digital technology and embracing that. But I suppose from a hospice perspective, the coordination of compassionate end-of-life care is really important for older people. And I just wonder how often we ensure that we are asking people around their preferred place of care and preferred place of death. Are we encouraging those conversations in older populations? Do we respect the decisions? Do we document them? Do we share them across the system? And I don't think we do across the whole health piece. And I think it's certainly an area for improvement in our system and wider. I'm going to move on to points 13 and 14, which is around making frailty everybody's business through training and developing the frailty workforce. And just to use our example at the Jean Bishop Centre. So we have about 70 staff now. When we started, we had about 15. And it has taken us 5 years to grow to this point. But we've had 2 advanced nurse practitioners. We've got 15 now. We had 3 GPs with an extended role in frailty. We have 12 working. We've got 12 in the team, but it's 5.5 whole-time equivalents because the majority of them still work within primary care, which again helps from a training perspective back into primary care around holistic assessment of an older person. And we've run with gaps until we feel that the right person is there for us to recruit. So I think that's part of our workforce development plan. But we don't struggle to retain staff, and I think that's because, you know, Ray's story is not in isolation. People can see the work makes a difference. I'm not going to go too much into this now because I'll run out of time, but you know, I've demonstrated to you some of the benefits I feel that exist within our system, but there's still a lot more to do. But I think making frailty everybody's business is something that we have been passionate about. We train across our 220 care homes, our primary care networks, and other areas as well. So in terms of top tips, I think one of the things that I benefited from as a clinician was having dedicated time for this. So we often are asked to do things without any protected time to deliver, and then we wonder why it didn't work in the first place. So, I mean, that was being key, is actually having, 4 hours a week or whatever, just to focus on this piece. But that relationship and trust piece as well, behaving differently around our integrated records and access. Co-location of services does help, but we have demonstrated that we can have tangible benefits for patients, even if services are not necessarily, if patients aren't seen on the same day by all services. My other point really is just that I've put in the top right corner here, if you're thinking of doing something frailty related, to start with small steps and build on that success through a PDSA cycle. But perhaps avoid pilots for pilots' sake. There's a lot of evidence of pilotitis across frailty care. We know what works, we just need to implement it, and where it's not working, just refine it. And so where might the hospice be able to help? Well, thinking about palliative care needs of an older person, these are just 2 data sets that I pulled into the slides from our Power BI dashboards. So the left one is urgent community response. So 440 of our calls that came through were for patients who were requiring palliative or end-of-life support. And I think that's a massive underestimate, because a lot of the calls that will come through will be because somebody's delirious or because they've fallen. And it might be that once we try to treat the acute illness, that actually we recognise that the patient is dying or approaching end of life and therefore requires end of life support. But I think there's need there. I also think there's need on the virtual ward. Our first 500 patients or so, 22 of the patients died, which is in keeping with what I would expect as a hospital-based geriatrician on an elderly care ward. So there are needs there, and I would suggest we have a skill set, but perhaps we could do more with some more specialist skills, working more closely with geriatric medicine. So I give thanks here to Dr. Antonia Fieldsmith. I had a call with her. They've got a similar model in Epsom and St Helier, and many of you may know Antonia, but a palliative care consultant working within a frailty service. And I'd never heard the phrase palliatrician. She assures me it's not her phrase, so she asked me to take this off the slide, but I put it on anyway. But but palliatrician is great, isn't it? Because I think I've got a skill set. I know my palliative care consultants that are here today, the colleagues I work with, have a different skill set. And we've got this overlapping area, probably between primary care as well, where if we were all working in this space together, we could upskill one another such that if that person wasn't there on a day, the patient would still get a adequate level of care. And therefore, it's great to see the work that Kat was telling me about earlier in terms of Hospice UK and extending the frailty care programme. And so I'm aware of the 11 sites that are signed up to this to improve quality of life for older people with advanced frailty who may have palliative care needs. And I've just tried to summarise the 11 sites. I was really excited when I was reading about this. Because I think a lot of those strategic principles that I mentioned earlier are covered by the themes that these sites are focusing on. So we're really excited to see the outcomes from the Extending Frailty Care Programme when that's completed. But what I would say is that even if you're not one of the 11 sites, I think there's a real space here for hospices in particular to be involved in system frailty work. I think all 14 of those principles I've put a tick against. I've changed the wheel here to say if we had a hospice without walls, it doesn't necessarily need to be a community frailty team, but we could all be part of the same team. And I think the hospice has got a role to play in the care of older people who are living with frailty, who are reaching the end of their natural life. Sometimes it's more difficult to predict when that might come. So even from an urgent community response or a proactive care or a virtual ward, there is a lot that we could do if we are integrated better. And if you were keen to be involved, I wouldn't obviously start from scratch. I'd get in touch with your local frailty or elderly care teams as well. But I suppose one thing we could all do now, in my role as a trustee as well, is consider 3 questions really. What's our access like for people living with frailty to our hospice care? What do we do to outreach into the areas of most need for people with frailty? Are our inpatient admissions based on frailty? Is it a criteria that we accept? Do we accept it as a long-term condition? And how do we share our information regarding our assessments of frail people across the system? I'm just drawing to a close. So I was at a care home in Beverley near my house a couple of weeks ago. It wasn't the one at the top, which doesn't look like the kind of care one would wish to receive in a care home. It was in the one in the bottom right. So this is Stuart, this is my wife's grandfather, and this is his 95th birthday, and he's having a glass of champers, he has dementia, and he's got his cake. And he looks great, doesn't look frail. And then 3 days later, he started on Aricept and he's climbing up the walls. And that's what can happen, isn't it? That minor insult and the impact it has on health. There is so much unmet need in care homes. It is a fascinating place to go into if you've not been and done a care home visit. There is so much medicine and pathology in an individual patient, let alone in all the residents there. And they are our most complex patient cohort who often have significant issues around capacity and guilt from a family perspective and concerns around finances and all the other things that impact upon care home placement and, of course, maybe approaching end of life. But it can be fun as well because just like in palliative care medicine, geriatric medicine can be complex, and actually having a problem list of sort of 10 to 15 points is really rewarding if you make some minor changes in each of those domains and it improves the patient's outcome. So when the slides are shared, my contact details and my colleague Dr. Anna Folwell, so we're both consultant community geriatricians and we lead the service together. So you got me today, but Anna's details are on there as well. And just some links to some pieces that we've been involved in, including Panorama, which was undoubtedly the scariest thing I've ever done, particularly when you can't see the video before it goes out, and Panorama normally investigates, but they were really good. So I think they reflected a frailty piece really well. So I just want to say a few thanks to members of Hospice UK, and thank you for inviting me to speak today. It's been a real pleasure, but particularly to Candice and Anita for their help in the prep for this, and to Professors Merter and Johnson for their work in evaluating the work that we're so heavily involved in. To my colleagues at House Hospice, who obviously I'm still on the board of trustees if they'll have me, but you know, I think it's given a geriatrician a really good insight into the right kind of care towards the end of life, and I find it really inspiring. And obviously to my colleagues at the Jean Bishop Integrated Care Centre. So I'm now going to hand over to Jean Bishop. So Jean Bishop is a British Empire medal holder who passed away at the age of 99. She's a lady from Hull. She started raising money for Age UK in her pensionable age because she took it upon herself to make a bee costume and go around the shopping centres across Hull and East Riding, rattling her tin for Age UK. She affectionately became known as the Bee Lady of Hull. She's a Pride of Britain award holder. You've seen her with David Walliams earlier in some of those slides. And she's a Freeman of the City of Hull. But for me, on a personal level, she's one of the most inspiring ladies I've ever met. And to have a centre named after a living person while it opens, a person that is respected and known by other people from the same demographic, really helped us to reach out to patients that were mistrustful of services and people that they didn't know. So without further ado, I'll hand over to Jean for final thoughts. Thank you.
Service, sometimes it's a good thing. I came to this house when it was first built, and that would be about 60 years ago. I couldn't go anywhere else. I like this house, and I like the surroundings, and I get on with everybody, all the neighbours. If there's an emergency, we know they're there. I love to get on with the job. As I got older, the problems started a bit. A few aches here and a few pains there. Then you started to notice that you couldn't do things. And that does irritate me when I can't do things. But to be in your own house, you can please yourself. And I think that's what makes you a lot better. You've just got to think, well, at least I'm here. Healthcare nowadays has got more up to date. They seem to know more. Everything's catered for. And I don't think they want for nothing there. And it looks so good, and everything's up to date. Everything in one place. It should be all under one roof and have it all then, there and then, when you go. I saw the doctor at my place. Hey! The place I've just been to. I said, am I your first patient? He said, yes. Oh, he's ever so nice. He really is. I got on lovely with him.
So what we're trying to deliver here is a totally different way of looking after older patients. So the patients that have been identified via their GP practices will be referred into the system here. They'll be attended to at home by a member of the team who will carry out an assessment of what the patient wants to receive when they come here, what they think that they're struggling with, what skills they have that they wish to maintain, really around promoting independence. If there's a carer or a family member, we'll also carry out a carer's assessment, so that when the person come here for their scheduled appointment, we know which members of the team they need to see. The kind of team members you'll have here is a geriatrician like myself, an older person's consultant, and there's 4 of us in the team. There's also GPs with a specialist interest, advanced nurse practitioners, pharmacists, therapists in terms of physio and occupational therapists, social services, and the voluntary sector.
Oh, they're lovely, aren't they? Every one of them. They're ever so nice, they are. Oh, I could go and spend a day in there with them. Yes, and I did some physio from someone from the fire service, and I was showing him how to do it. He said, well, my arms are I'm really tired. I said, get on with it. You want to do it like this. I finished up showing him how to do the weights.
We wanted the space here to feel very welcoming and warm. I feel this is a real future-proof building for older people's care. We can do it here in a one-stop shop. People can have answers on the day. They'll have a care plan that they can take a copy of, take home with them. I'm confident that what you'll see is that people feel that we're engaging with them more, that we have the time to care in the way that we wish to care for them.
I felt really honoured, and I still can't believe it, because I thought, why? I'm asking myself why it is. But I can't believe it, and when I see my name up there, I think, no, they've got it wrong. I hope it's going to be a really good success, because what I've seen of it today, it's out of this world. It's really lovely.
Dan, we think you're really nice too. We've got a great number of questions coming through. I'm sorry we're not going to be able to handle them all today, but one theme that's coming through is this interrelationship between care of the elderly, care of the frail, and hospice care, and that feeling, there wasn't so much of Dove Hospice there, and that feeling of territory.
Yeah.
How have you built that community together?
I don't know. I think having a really clear vision around what we want to do differently as a system, being able to demonstrate with evidence the things that will make a difference, and therefore it's a hearts and minds piece of system leaders to say, actually, no, we're going to invest in this because we can see it makes a difference and we know that patients will have a better experience. And I think it's either a bottom-up or a top-down approach, but from a top-down approach, if system leaders are saying this is what we're going to do, a bit like what I was hearing yesterday, really difficult discussions and decisions, but if that is made, it makes the lives of people like myself much easier for getting on and delivering a clinical model that we know can work. And then when you find, colleagues, I mentioned Fliss earlier, but who will help you evaluate something like this is for me how different specialist services can work together. It's not necessarily all about us all delivering the same episode of care, but working out the strengths and weaknesses in our system and pulling on other people's strengths to help you get to the place where you need to be.
It's just in looking at the videos and hearing you, so much of what you're doing, it just sounds like palliative care should be, and yet it doesn't have a big palliative care label over it. Yeah. And it's really exciting to see. One of the things that has come from the audience is concern over note sharing and data sharing. Yeah. Somebody comments that they've got 5 different EPRs to deal with. How did you get around that? So
I think we are in a better place. We still have 5 or 6 different EPRs, but it's around our information tech teams across the different providers actually finding ways in which we can view the different EPRs. So like, for example, the hospital EPR, all our clinical staff in the Jean Bishop model have access to that. It does mean that there isn't a consensual login. You need to log in several things on a computer at the same time. But our admin team have the rights to put our documentation into the hospital EPR. You know, these little things that if we'd asked to do this 6-7 years ago, well, we did actually, if we'd asked 10 years ago, we'd have probably been told you can't do this. But actually, going back to that everybody pulling in the same direction piece, a lot of the data governance issues can easily be sorted if you can just get people on side with what you're trying to achieve. And the pandemic taught us that as well.
Yeah. Data issues easily sorted. Yeah.
Ish.
Fantastic. Yeah, fantastic session. Thank you. How influential is your place-based model in recruiting and retaining staff? If I were a student nurse, I'd be climbing mountains to work in such a collaborative and relational way. I can see a future for advanced practices becoming the norm. And have you been able to open up more placement options for student nurses?
Yes, so we have student nurses, physician associates. We've created a GP VTS training program, so we've got 5 GPs rotating through our team every 6 months, none of whom have actually gone on to work with us, which is actually great because we need really good GPs working for older people in primary care as well. So therapy students. I think one of the most pleasing things for us is the way that we've worked with the other provider organisations on rotational posts of qualified members of staff as well. So we have therapists who rotate between the acute trust and ourselves, and we have the meds management team, the pharmacy and the pharmacy technicians on rotational posts. Because what we don't want to do is bleed other areas of the system that need really good staff as well, so that we have an excellent community-based frailty service and then nothing elsewhere.
Yeah. Can I bring to a last question? And that is, for those of us out there who are keen to be involved in this sort of work and see our hospices maybe being connected in this sort of work, how would you encourage us to approach community geriatricians or the frailty services? How can we do that without generating antibodies but building friends?
It's a really good question. I mean, I think it's a bit of a sorting hat, geriatric medicine, isn't it? Sorry to use Harry Potter, but like, I don't think we're a nasty bunch. And I don't think hospice teams are either, or community-based palliative care teams. I think those conversations are easy. I think the hard bit is finding the capacity to do the work. And so, in my experience, I mean, I'd love it if people approached us and said, we want to work more collaboratively with you. But I know lots of colleagues around the country that would feel the same. I think everyone's a bit burnt out at the moment, the thought of trying to take on something new. And this is quite a large area, isn't it? For me, I think if we would start somewhere from a hospice movement into the community, and there are really good examples around the country, but care homes for me, we have over 6,000 care home residents across 210 homes. The wealth of need in there is significant, and if anybody wanted to help us, it would be great.
Thank you very much indeed. Can you